Our next presenter is Dr. Ann Schott of the Rogel Cancer Center, University of Michigan Health in Ann Arbor, who will present GS303, ARV-471, a PROTAC estrogen receptor degrader in advanced ER-positive, HER2-negative breast cancer, Phase 2 expansion, VERITAC, of a Phase 1/2 study.
Good morning. I'm Dr. Ann Schott, and on behalf of my co-authors, I would like to thank the SABCS organizers for the opportunity to present data from the Phase 2 portion called VERITAC of a Phase 1/2 study of the PROTAC estrogen receptor degrader, ARV-471, in patients with ER-positive, HER2-negative advanced breast cancer. ARV-471 is a PROTAC protein degrader that can degrade both wild-type and mutant estrogen receptors. ARV-471 directly binds both the ER and an E3 ubiquitin ligase to initiate ubiquitination and subsequent proteasomal degradation of estrogen receptors. This differs from SERDs, such as fulvestrant, which cause degradation secondary to ER conformational changes or immobilization. ARV-471's distinct mechanism of action may provide more robust ER degradation, which may translate to stronger anti-tumor effects. In support, in preclinical studies, ARV-471 degraded over 95% of estrogen receptor and showed greater tumor growth inhibition than fulvestrant. The focus of this presentation is the VERITAC Phase 2 Cohort expansion portion of a multi-part Phase 1/2 study of ARV-471. The primary objective of VERITAC is to evaluate the anti-tumor activity of once-daily orally administered ARV-471. Part A was a Phase 1 dose escalation to evaluate safety and tolerability and to select the doses for the VERITAC Cohort expansion. Part C is a safety, tolerability, and dose escalation study of ARV-471 in combination with palbociclib. Results from the Phase 1 dose escalation were presented last year at SABCS. ARV-471 was well tolerated at all doses, with no dose-limiting toxicities or grade 4 or 5 treatment-related adverse events. The clinical benefit rate of ARV-471 in the Phase 1 portion was 40%. All of the patients had progressed on or after a CDK4/6 inhibitor regimen, and this included 3 patients with confirmed partial responses. The pharmacokinetics of ARV-471 were dose proportional, and mean exposure on day 15 exceeded the non-clinical efficacious range, and up to 89% degradation of estrogen receptors with ARV-471 treatment was observed. Patients eligible to enroll in the Phase 2 VERITAC expansion had ER-positive, HER2-negative advanced breast cancer and received 1 or more prior endocrine therapy regimens, prior CDK4/6 inhibitor therapy, and up to 1 prior chemotherapy regimen in the advanced setting. Patients were assigned to 200 or 500 milligram once daily oral dosing groups. Enrollment in the 200 milligram cohort began before enrollment in the 500 milligram cohort. The primary endpoint was clinical benefit rate. Secondary and exploratory endpoints are shown. The data cutoff for the results shown here was June of this year. Patient and disease characteristics for the VERITAC population reflect those of an advanced breast cancer population. 58% of patients in this Phase 2 cohort expansion had ESR1 mutation positive tumors. The population was heavily pretreated, with a median of 3 prior lines of therapy in the metastatic setting. All patients received prior CDK4/6 inhibitor therapy per the inclusion criteria. 90% had prior aromatase inhibitors, 79% had prior fulvestrant, and 45% had chemotherapy in the metastatic setting. The baseline characteristics were similar in the 200 milligram and 500 milligram cohorts. In terms of safety, only 3 patients in the 500 milligram cohort had adverse events that necessitated a dose reduction to 400 milligrams once daily. No patients in the 200 milligram cohort required a dose reduction due to adverse events. 1 patient in the 200 milligram cohort and 2 patients in the 500 milligram cohort discontinued ARV-471 treatment due to treatment-emergent adverse events. The majority of treatment-related adverse events with ARV-471 were mild or moderate. Overall, 34% of patients had grade 1, 31% of patients had grade 2, and 7% had grade 3 or 4 treatment-related adverse events. The proportions of grade 1, 2, and 3 or higher treatment-related adverse events were similar in the 2 dosing groups. The most common treatment-related adverse events were fatigue, nausea, arthralgia, hot flush, and increased AST. Apart from 1 grade 3 fatigue event, all were grade 1 or 2. Here we show the primary endpoint of VERITAC. The overall clinical benefit rate was 38%, which is notable given the heavily pretreated patient population. The clinical benefit rate was similar in the 200 milligram and 500 milligram dose cohorts, 37.1% and 38.9%. We also looked at the clinical benefit rate in the subpopulation of patients with ESR1 mutation-positive tumors. It was 47.4% in the 200 milligram cohort, 54.5% in the 500 milligram cohort, and 51.2% overall. This is notable given that ESR1 mutant tumors can be resistant to endocrine therapies, including fulvestrant. Turning to the secondary endpoints, here's a waterfall plot showing the tumor responses observed in evaluable patients in both dosing cohorts. Patients with tumors harboring ESR1 mutations are indicated by the cross-hatched bars. 1 patient in the 200 milligram cohort and 1 in the 500 milligram cohort had a confirmed partial response. An additional 5 patients with target lesion reductions greater than 30% had unconfirmed partial responses, and therefore their best response was reported as stable disease. Progression-free survival was evaluated in the overall population and the ESR1 mutation-positive population for both doses combined, shown in purple, and for the 200 milligram cohort, shown in blue. The 500 milligram cohort, which started enrollment after the 200 milligram cohort, was not mature at the time of the data cut and is therefore not shown. The preliminary median PFS was 3.5 months in the 200 milligram cohort and 3.7 months in the overall population. Median PFS was 5.5 months in the ESR1 mutation-positive subgroup at the 200 milligram dose and 5.7 months in the total ESR1 mutation-positive subgroup. Estrogen receptors were evaluated in paired biopsies from a subset of patients in the phase 1 portion and VERITAC before and during ARV1 treatment at the 200 milligram dose. Consistent with ARV-471's mechanism of action, there was a median 69% decrease and a mean 71% decrease in estrogen receptors during treatment. In conclusion, in the VERITAC expansion cohorts, the PROTAC-ER degrader ARV-471 showed encouraging activity in heavily pretreated patients with ER-positive, HER2-negative advanced breast cancer, with a clinical benefit rate of 37.1% in the 200 milligram cohort and 38.9% in the 500 milligram cohort. Clinical benefit was observed in the patients with tumors harboring ESR1 mutations, with a CBR of 47.4% in the 200 milligram cohort and 54.5% in the 500 milligram cohort. The manageable AE profile that was observed in the phase 1 portion of this study was maintained during cohort expansion. Most AEs were grade 1 or 2. Based on the totality of the data, including comparable efficacy, favorable tolerability, and robust ER degradation, ARV-471 200 milligrams once daily was selected as the phase 3 monotherapy dose. The randomized phase 3 VERITAC-2 study will compare the PROTAC ER degrader ARV-471 at a dose of 200 milligrams orally once daily versus the SERD fulvestrant administered intramuscularly in patients with ER-positive, HER2-negative advanced breast cancer with a target enrollment of 560 patients. Key inclusion criteria are 1 line of CDK4/6 inhibitor therapy in combination with endocrine therapy, up to 1 prior endocrine therapy, no prior fulvestrant and no prior chemotherapy for advanced disease, and progression on the last line of therapy. The primary endpoint is progression-free survival by blinded independent central review. My co-authors and I thank the patients who participated in this study and their caregivers, as well as the researchers and others who contributed. A plain language summary of this presentation is available through the QR code. Thank you.
Thank you, Dr. Schott, for that fantastic presentation. We'll look out for questions in the audience. All right, well, while we're waiting for folks to come to the microphone, one of the questions is why might ARV-471 work better in the ESR1 mutant subset?
Well, I think that was actually well addressed by Dr. Kaklamani in her Q&A, so thank you, Virginia. The ESR1 mutant population of patients who've been previously treated with endocrine therapy probably still maintain endocrine therapy sensitivity except through the mechanism of ER signaling through the mutant protein. In other words, ARV-471 can attack that solitary mechanism of resistance, and those tumors may not have developed other mechanisms of resistance.
Excellent.
Microphone 3.
Thank you. Roberts, Nottingham, Derby. You focused almost exclusively in the ESR1 mutation, and the clinical benefit rate you said was increased from the average of 40 to 50, and the PFS rate was increased from 3 to 5 months. That implies that the clinical benefit and the PFS rate in the patients who didn't have mutations must be very low. Can you tell us what those were, the clinical benefit rate and the PFS rate in the non-mutant? And is that why in the phase 3 trial you've mandated that it must have prior CDK and focusing on your ESR1 mutations?
So to answer the first question, the clinical benefit rate in the ESR1 wild-type patients was 20% in this heavily pretreated population. The phase 3 trial will enroll ESR1 wild-type patients, but it is looking for patients who have had at least 6 months of prior endocrine therapy in the hopes to find endocrine-sensitive populations. In the end, this is an endocrine therapy, and patients need to be sensitive to endocrine therapy for this therapy to work. Not all ESR1 wild-type patients are resistant, and so this treatment can benefit them, therefore delaying future need for chemotherapy or other more toxic therapies.
Can I ask what the PFS
you.
was? Didn't.
Microphone 4.
Thank you. Dowsett, London. You showed us a suppression of the estrogen receptor levels in your paired biopsies of around 70%, which might be deemed to be incomplete. I'm wondering whether competition still with the PROTAC at the estrogen receptor site downregulates estrogen receptor signaling, and whether you looked at, for example, TFF1 or progesterone receptor levels in those paired biopsies.
So at the current time, that data is not available.
Okay. Thank you very much. Thank you again, Dr. Schott. Our